So this video, I'm going to show you a case of a post-traumatic accidental history of fall from bike following 15 hours, from which the patient started experiencing watery discharge from right nasal cavity. So the patient falls from his bike, suffers minor and some major bruises over the face and the body, and within a period of 15 hours, he experiences a right-sided nasal watery discharge. Though initially it was very small in amount, but also the patient had complaints of right-sided temporal bone blunt trauma, along with blockage of ears and decreased hearing, along with pulsatile tinnitus. So the history was like this, and following which, the very second day, the patient's amount of right-sided nasal watery discharge started increasing a lot. So the patient, whenever he used to go for a bending forward position or used to strain while defecation, the patient had experienced a lot of nasal watering from right side. So the right-sided nasal watering was present much on straining and bending forward. So an assumption was made that the patient was having a history of trauma, and then hence following which he started having the right nasal watering. So assumption of CSF leak was made, though beta-2 transferrin should be done immediately after collection of the sample, but certain places beta-2 transferrin can take a lot of time, say roughly from 3 days to 5 days for its process, and we may not have that much time to diagnose whether it's CSF or not. So what we do in such cases, now assuming that he also has a blunt trauma on the temporal bone region, he could be suffering from a fracture. Depending on the type of fracture, it could be a transverse or a longitudinal fracture. We got the patient's CT scan done. Now, not just the plain CT scan, having the point in mind that he also has he could also be having a CSF leak. We got the patient's CT cisternography as well, along with the plain HRCT with cisternography. So as you can see on the screen, this is a patient's cisternography. Now there are two parts to this CT scan. Now in this lecture, I'll be covering about the CT cisternography of the paranasal sinus, that's the anterior skull base. And in the next lecture, I'll be talking about the fractures of the temporal bone on the CT scan along with the cisternography. That's types of two fractures, longitudinal and transverse fractures, I'll be covering up in the next lecture. So as you can see, this is a patient's cisternography, and I will show you the patient's report as well. Now as you can see over here, this is a patient's report, and depending on the report, it's mentioned that approximately there's a 2.2 mm defect, a bony defect in the area of the cribriform region. To be precise, it is in the region of the right fovea ethmoidalis and the cribriform plate, which roughly makes up the posterior medial wall of the right frontal sinus. So nowhere else in the entire anterior skull base there was any leak, at least though on the CT scan they could not find that any other secondary site of leak or any bony defect. The rest of the cribriform plate, the entire region of skull base was completely intact. The sphenoid sinus, roof, planum, everything was intact. And also, there's only one defect they could see on the area of the cribriform plate. So what happens exactly in the CT cisternography is that the patient is given intrathecal injections of a low molecular weight non-ionic contrast agents, and which gets mixed up with the patient's CSF and travels the entire CSF pathway. And if the patient is having an active leak, when the patient is in the prone position while on the CT scan machine, this contrast will seep out in the nasal cavity, and hence to confirm that that's the radiologist also puts cotton pledgets in both nasal cavities to make sure that really there was an active leak. Okay, so as they have mentioned, the right cotton pledget shows contrast opacification in it on the post-procedure images. Hence, it is confirmed that the patient was having an active CSF leak. So in this case, beta-2 transferrin is not supposed to be done, because we should not wait for long times for the report of beta-2 transferrin to come in. Okay, so we can directly go for CT cisternography if the beta-2 transferrin reports have not come yet. Okay, so this confirms that yes, the patient was having CT positive findings for CSF leak of that patient. Now As you can see over here, this is the arrowhead which is showing the defect in the cribriform plate, which is just posterior medial to the frontal sinus opening. And this is the sagittal, and that's the axial view. A very small break though in the bony region, and this on the coronal scan, you can see the exact area of the bony defect. As you can see, the hand of my cursor is the area of the defect. You can see both the arrow. The arrow is pointing out towards the fracture segment, and the superior arrow is pointing out towards the defect caused by the fracture. So this is the area where the contrast is seeping inside, and some of it was going in the frontal sinus, and directly when the patient is to bend forward, the patient was having the leak from the right nasal cavity. So this is a CT scan. Now I'll show you the dynamic CT scan. As you can see, this is a patient's right frontal, this is left frontal, the left being more dominant, I guess. The right showing opacification, as we can see over here, and we are going from the anterior to the posterior aspect. So we can see all the way throughout the frontal sinus is having opacification on the right side, and roughly in this area you can typically see a bony defect. There's a clear-cut bony margin which is deficient over here, and you can see the collection in the frontal sinus happening over in this period. And this is the area of the bony defect, clearly seen if you can compare both the sides, the right and the left intact, pretty much intact. We can see the bony margin over here, but the same side, on the right side, you can see a deficient area where the bony margin is not seen. This could be the area for the active leak the patient was having. And so if we still keep on going behind, we can see that there is some fluid collection over here, and the rest of the area seems to be normal without any traumatic positive findings over here. Although we do see that the patient's sphenoid sinus is having a lot of collection as well. So far, yeah, mostly in the posterior aspect. So as you can see, a small collection area in the posterior aspect of the right sphenoid. So this could be the collection of that sphenoid sinus. Apart from this, everything seems to be quite normal in the patient's CT cisternography. And the patient went on to have a continuous CSF leak for around 7 days. Now, the patient had a history of fall from bike following 15 hours, from which he started having right-sided nasal discharge. Frank, the amount kept on increasing, but after 3 or 4 days, the amount started to decrease, and then progressively the amount was very small. So over a period of 7 to 8 days, the patient was having the CSF leak, and the amount though decreased, but the patient had an episode of fever and headache, for which we started the patient on injection mannitol and tablet Diamox on the day 2 itself. So to control the symptoms of and to prevent the onset of meningitis, also we started the patients on empirical antibiotics on higher dose, which can cross easily the blood-brain barrier. So normally in cases, you can use cephalosporins, you can use vancomycin, you can use meropenem, whatever the drug of choice is, which easily crosses the blood-brain barrier and covers the broad spectrum antibiotic area. So do that, and the patient should be, now theoretically the patient should be observed for a minimum of 7 days. Max to max, we can stretch it up to 10 days, but with the risk that the patient might get meningitis anytime, even though we are taking a lot of precautions. So if the patient's CSF leak is not stopping, or it is very slowly, gradually, very slowly decreasing, you should consider the patient surgery. You should take in the patient for surgery to surgically repair the area. But if the patient is having very less signs and symptoms, or the amount of the fluid of the CSF is gradually decreasing over a period of 3 to 5 days, or max to max 7 to 10 days, then the patient should not be taken for surgery. But if the amount is very slowly decreasing over a period of 7 to 10 days also, and still the patient is having a CSF, frank amount of CSF leak even after 7 to 10 days, then surely you have to take the patient in for surgical repair, because to avoid the complications of meningitis.